Hello everyone and welcome to this evening's Facebook Live. My name is Claire and I'm Clinical Manager at Wound Care People. Just to remind you, we're broadcasting live from our homes, so if we have any technical issues at all, please do bear with us. Tonight's session is Managing Atypical Wounds, and our speaker this evening is Sharon Gardner, who is Clinical Support Specialist at H&R Healthcare. A big thank you to H&R Healthcare for their support this evening. And just to let you know, certificates will be available at the end of the presentation. You can send us any questions by commenting on the video. So without further ado, I'm going to hand you over to Sharon.
Thanks, Claire. So the purpose of tonight's Facebook Live, so the learning objectives are to recognise when a wound doesn't fall into a typical wound category, to understand that wounds may not heal with dressings alone and may only be used to manage the symptoms. So actually we may only be using the dressings and manage the symptoms that wound's presenting. To understand the importance of onward referral for histology or investigation, or maybe some specialist input for a treatment. And to also recognise the need to work with various multi-professionals to manage symptoms as appropriate. So to be able to recognise an atypical wound, we first need to consider what is classed as a typical wound. So really, in my mind, a typical wound is one that goes through all the stages of wound healing at the normal rate that we would expect them to. So it goes through the hemostatic phase, it clots, it goes through the inflammatory phase, where all those lovely fibroblasts and macrophages are released. You get your proliferation, your granulation of collagen, and then obviously your remodeling. That would be the term for an atypical wound. However, 20% of all chronic wounds are believed to be atypical. And an atypical wound can be suspected if the wound has an abnormal presentation. So if you look at it and think, well, that looks like a pressure ulcer, but it's not on a bony prominence or an area that's come in close contact with pressure. Or there's pain out of proportion to the size of the wound. So it could be a really small, punched out looking lesion that is absolutely agony for the patient. And then obviously using the UMA definition, it's a wound that doesn't heal within 4 to 12 weeks with a good treatment plan for that type of looking wound. So the first atypical wounds that I'm going to touch on briefly are self-harm wounds. We know that the incidence of deliberate self-harm is on the increase. We know that mental health is worsening in people that already have mental health conditions, and even those that necessarily haven't had previously. We know that some of the injuries range from minor superficial injuries to major trauma, life-changing injuries, and such as genital self-mutilation and attempted suicide. Individuals who self-harm tend to use more than one method over time. We know that some individuals may prefer a sharp object, or they may move on to something different when they don't feel they're getting that expression of emotional distress. They're not getting that distraction that self-harm would give them. And obviously the picture shows us some old cigarette burns. In thinking about healing these wounds, we know it's not just about the wound. We know that an MDT approach is needed, and we have to understand and support the mental health needs of the patients. We know that they need plenty of support mechanisms and self-care items, and that might be that actually people that have a history of self-harm have their own stock of antimicrobial washes or simple wound care products so that they can cleanse the area and cover it with a dressing until they can seek support. Always be aware when looking at a wound, doesn't matter how obvious it seems, that there could always be something else. What about something else? There could always be a differential. So obviously with self-harm, we should always be thinking about dermatitis artifacta, so that unconscious self-harm that's occurring is, these injuries are happening and people aren't knowing, or the dermatitis para artifacta, so the skin picking syndrome where people will sit and pick at a lesion for a long period of time without realising they're doing it. And obviously it's very important also to consider safeguarding. These patients may be presenting with what appears to be self-harm and they're telling us it's self-harm, but actually the clinical picture doesn't fit. The next skin type or wound we're going to look at is piercings and tattoos. Obviously, people who have had tattoos or know people that have had tattoos, we know that just by the mechanism of the tattoo that it can lead to minor inflammation, and that's probably quite normal. But depending on the circumstances, there may also be a risk of infection and other types of reaction. And obviously in the image there, there is a tattoo in the background, but that reaction is a dermatitis reaction, so an allergic reaction to some cleansing agents that have been used for piercing. Obviously, in terms of tattoos, reputable, clean licensed tattooers should always be used, and they should obviously be using ink that's not contaminated to make sure the risk of infection is low. But like I've already said, by the mechanism of the needles piercing the skin multiple times, that skin barrier protection is broken, and individuals can get real cellulitic infections from having a tattoo done. Obviously, in terms of treating, we want to promote effective self-care to maximise the healing. We want to minimise the risk of wound infection, which could obviously go on to lead to something serious as sepsis, and also consider long-term complications such as scarring or tattoo disfigurement, which can be quite detrimental to an individual and may have paid a lot of money to have this tattoo done. We should always think about scarring, hypertrophic scarring, but that is something that should always be asked by the piercer or the tattooist prior to having the treatment done. And it's just about basic, strict hand washing and cleanliness of the area. Thinking about oral piercings, antibacterial mouthwashes can be used, and obviously antibacterial washes, gentle antibacterial washes for genital piercings. There's little evidence out there around topical preparations. Obviously, different tattoo studios use different products as an aftercare ointment or cream, but obviously we need to think about a lot of these contain lanolin, and we know that obviously lanolin causes multiple skin sensitivities. So these are things that really we need to be looking at when considering how to care for tattoos. But importantly, if these do become infected, then systemic antibiotics really is the only way to treat them. Okay, so the next skin condition that I really want to talk about is bullous pemphigoid. And bullous pemphigoid is a rare autoimmune blistering disease, and it's to do with the IgG autoantibodies. And basically they bind to the skin's basement membrane in patients with pemphigoid disorders, and it activates an inflammatory mediator. When the autoantibodies attack the basement membrane, it causes these subepidermal bullae that obviously we can see all over the image that we can see there. The subepidermal blisters, we do not deroof them as clinicians. You know, we leave them intact as that protective mechanism in the hope that they will reabsorb into the body. And it's also, you know, important to think that these people that have BP, they can have a lot of large blisters that are intact, quite tight looking, rather than blisters with scabs that we do tend to see in pemphigus vulgaris. BP commonly affects people over 70 years of age, and reoccurrence is common after that initial autoimmune presentation. It is common for them to get a reoccurrence. We know that risk factors can be triggered by external factors, such as drugs, stress, pregnancy, and actually removal of that trigger. So post-pregnancy, post-delivery, it doesn't always resolve the condition. We know it's common in older age groups and people who are on multiple medications, so polypharmacy, and it is also associated with other autoimmune diseases. So again, thinking about the differential diagnosis and the considerations that I mentioned to you previously, is it something else? Is it blistering due to excess edema in the tissue, which is commonly seen when the edema causes so much pressure in the tissues, you just get these covered area of fluid-filled blisters? Is it a blister related to a burn? You know, has that person sustained a burn on a limb and it's come up in these blisters? Is it a skin reaction, a bullous drug eruption? Are they bites or are they friction, like we commonly see in pressure ulcer associated damage from friction? Could it be something as simple as the herpes virus? You know, when we see chickenpox, shingles, that they start off in these really small clusters of blisters. Is it something like that? Or is it malignancy? Is it a form of skin cancer? Is it some other strange bullous eruption that isn't related to obviously the symptoms of BP? Or is a parapox virus, which is contracted from farming, so goats and sheep, or people working in the meat industry, and that presents as firm red blisters or like a bluish lesion that then progresses into a blister. So it can look similar to bullous pemphigoid. But obviously, if your patient's worked in an office the whole life, they've not come into contact with animals, then it's unlikely to be off. So it's always thinking about that clinical picture. What's going on with the patient? What's their history? So thinking about treating patients with BP, so it's obviously individualised treatment regimes for that patient, and that usually comes from prescriptions and recommendations from dermatologists. So generally, people are prescribed the lowest dose prednisolone that is possible to treat their symptoms, with occasional increases in doses if required, and then decreasing back down. Obviously, the aim is to reduce the blister formation and control the disease process, and obviously promote the healing of the blisters and the lesions, encourage those blisters to reabsorb before they break down, and obviously heal those lesions. And monitor that patient progress very closely, because they can change from one day to the next, and that's to make sure that they are not developing any other symptoms, and that's until they are in remission. And it's especially important to look out for signs of infection. So treatment, as well as obviously oral prednisolone, topical steroids can be beneficial to incredibly wet or painful ulcers where the blisters have deroofed, and sometimes oral anti-inflammatories are given alongside the prednisolone. And then we need to think about obviously managing those wounds and encouraging them to heal by means of moist wound healing. And the best type of dressing to use on these lesions, due to the pain and the fragility of the skin, is a silicone foam dressing, because we obviously want to minimise further trauma on removal. So the next skin condition, and I do apologise if you can hear the police helicopter that is incredibly low circling over my house, it's very off-putting. The next condition is pyoderma gangrenosum. Again, it's a really rare autoimmune ulcerative skin condition, and sadly, a lot of it is unknown. The etiology of it is not fully understood. So the name refers to ulcers with a blue-black edge, which progressively worsen, and obviously in the image we can see the ulceration there next to a stoma. We know that approximately half the people with PG have an underlying systemic disease, which is usually an ulcerative colitis, Crohn's type disease, hepatitis, or obviously rheumatoid arthritis. And it's also important when considering taking history and thinking about all the other past medical history that patients might have, that PG actually has a higher incidence when people have got a first-degree relative with it, so a mother or a father. We know the presence of abnormal neutrophils and T cells lead to an immune dysfunction, and that then in turn increases the levels of inflammatory mediators. We also know that previous healed sites where ulceration occurred are known to be susceptible to relapse and for those ulcers to break down again. The T cell activity targets the follicular adnexal structures, so those skin structures that serve a purpose, so the ones that have the sebaceous sweat glands within them. We know that the clinical presentation can originally start off with papules, nodules or pustules, so all the lumpy, horrible looking blistery type presentations, and they mostly develop into these blue-black edged painful ulcers within quite a short space of time. So if you're seeing lesions that are changing very quickly, then always have that suspicion in the back of your mind that this is an atypical wound. PG can affect any part of the body, but it generally is the lower legs. And obviously, you know, that it's 70% that it affects the lower legs, and that can cause a lot of confusion, misdiagnosis and treatment, because we may be thinking we're treating an arterial or venous leg ulcer, which can also deteriorate quickly due to however the blood flow is and also be painful. Interestingly, PG can also occur post-op at the site of surgery and can sometimes be misdiagnosed as a surgical site infection, but it's actually a post-surgical pyoderma gangrenosum. So again, very quickly, could it be that? Could it be something else? Could it be vasculitis, so the inflammation where you've got the destruction of the walls of the blood cells? Could it just be venous leg ulcer, like I've already mentioned? Could it be a malignancy? Have you got the start of a fungating wound there, surgical site infection? Or could it just be a non-healing wound? And obviously we've already mentioned one of the parasitic infections, but could it be something else? So in terms of treatment, again, it's paramount that these patients get the correct diagnosis from specialist involvement. And they use a criteria to be able to diagnose effectively, and it's usually biopsy of the ulcer edge to look for a neutrophilic infiltrate. They'll look at other things like the occurrence, multiple ulcerations, what's the pathogy occurrence, is it the lower leg, what's the past medical history. And obviously in terms of treatment, again, dressings are going to manage the symptoms of the wound, but the treatment is going to be the immunomodulatory therapy or immunosuppressant therapies, topical steroids or oral steroids. But also you need to think about what other systemic therapy do they need. Do they need analgesia? Do they need strong analgesia that you wouldn't expect they would need from a lesion of that size? And thinking about wound therapy, knowing that obviously that these patients are on multiple medications that can change their immune system to try and get a balance and manage the PG, they are highly at risk of infection, of wound infection from these open areas. So we may need to think of using antimicrobials to prevent any infection occurring. So the next one I want to speak to you about is interesting really, and when I look back to my previous roles as district nursing and stuff, I know now that I've seen patients with this condition and perhaps not recognised it at the time, and that's why it's important to have sessions like this that refreshes our mind and makes us think a little bit. So hidradenitis suppurativa, so it's an inflammatory disease that primarily affects the hair follicles of the apocrine gland. So it bears within the skin and causes recurrent lesions. They consist of inflamed and non-inflamed nodules, so they can start with just very, very pale looking nodules that aren't particularly inflamed, and then they can fill up and develop these tunnels where they can drain pus. And obviously later stages of the disease, scarring is prominent. Again, the lesions can cause significant pain and discomfort. And when thinking about HS, we stage them using a scale called the Hurley stage. So stage 1, Hurley, would be a single bump with no sinus tract. Stage 2 would be more than one bump with perhaps a little tunnelling. And stage 3, you would see multiple bumps, lots of tracts, scars, and generally involving the entire body. Obviously, the most common area for it to present is the axilla. So you've got all those sweat glands, those apocrine glands there. But you can see it, in the whole body. We also know that HS is part of the PASH syndrome. So that is a hereditary autoinflammatory syndrome consisting of multiple neutrophilic dermatosis. So when you see pyoderma, you see HS, and then you see acne, which obviously we can see in the second picture, and that is very challenging. Although very rare, it's very, very challenging to manage those 3 autoimmune conditions together. So thinking about HS, is it a disease of wound healing? Would it be what we'd classify as a wound? Well, I personally feel that it is. We get chronic lesions characterised by a mix of inflammation and tissue damage. We then obviously get the formation of scars, tunnels, and occasionally hypertrophic granulation in the tissue. Again, etiology of HS is largely unknown. And chronic lesions in the later stage of the disease contain neutrophils and mast cells seen within surrounding tunnels containing an abundant biofilm. In terms of the etiology, it's thought that abnormal immune response to changes in the microbiome of the hair follicles may play a role in HS developing. We know the pathogenesis involves the release of pro-inflammatory cytokines and anti-inflammatory cytokines, and we've heard a lot recently, haven't we, about cytokine storms in relation to COVID-19, and obviously the body's own immune system trying to fight off various viruses. So in terms of HS, you've got your group of pro-inflammatory and your anti-inflammatory, and then obviously they're coming up against each other. In chronic lesions at that stage, MMP2s are expressed in the lesions, indicating cell migration that are associated with wound healing. So that's why I would argue that HS is a disease of wound healing. So thinking about treatment, obviously it's multimodal and actually interestingly consists of lifestyle changes and interventions, but there is no cure. Like a lot of these autoimmune complex skin conditions, there isn't a cure. It's just about managing the symptoms and recognising them early enough. Lifestyle changes include weight loss and healthy diet, plenty of exercise. None of us are probably getting much of that at the moment. I know I'm certainly not in lockdown. And smoking cessation, interestingly. And they're not 100% sure why that improves, but they know from multiple studies of people with HS, they found that those who smoked had more severe symptoms of the disease, and those that actually gave up smoking when they had a further outbreak, their symptoms weren't as extensive. In terms of treatment, So we need to consider dressing selections. So we need to consider absorbency. So if you've got areas of HS that are, leaking multiple amounts of pus and fluid, it needs to be a really good absorbent dressing. It needs to be able to lock fluid away, and it needs to be comfortable for the patient. If they've got to wear these dressings that may extend full torso, they need to be comfortable and they need to be conformable. So you may want to look at a silicone-based contact layer and a superabsorbent dressing like Cliniderm superabsorbent and Cliniderm contact layer, or maybe just a Cliniderm foam silicone is enough to contain the egg state that they're presenting. The Cliniderm range is cost effective. So, if the dressing changes are needing to be frequent or performed a lot by the patient, they're easy to use, they are not expensive, and they come in really large sizes, some of the dressings. So for that wrapping effect, if you've got a whole torso, they're really beneficial. Medical intervention includes topical treatments, but that's most suitable for the early stages or the mild stages. And some trials have suggested topical clindamycin may have some benefit, but again, these kind of treatment regimes would be from dermatology specialists. Systemic treatment primarily uses antibiotics and/or immunosuppressants, and ideally the symptoms will be managed by medical intervention, but there may be some chronic residual tunneling lesions that still need wound care input. The next one is a debilitating condition in which calcification of small and medium-sized arteries, most commonly the cutaneous and subcutaneous, generally occurs in patients with renal disease. Calciphylaxis causes ischemic necrosis of the dermis, subcut tissue, muscle fascia, and obviously internal organs, which lead to calcification of all those soft tissues, which would ultimately increase a patient's mortality. It occurs in about 35 out of 10,000 end-stage renal patients, generally those on dialysis, but the actual cause remains unclear. Risk factors include diabetes, obesity, female, generally more than male, and obviously those that are dialysis dependent. It isn't always patients with renal failure and can sometimes be related to patients who are morbidly obese, who have type 2 diabetes with hypertension. Again, thinking about the differential, is it necrotizing fasciitis? We'll come on to that very soon. Is it pyoderma gangrenosum? So is it PG? Is it bullous? Is it something related to lupus? Has your patient got lupus and they're coming out with these stained erythematous lesions? Is it COVID-19? And interestingly, a study that's been done, Rotman et al. This year, has looked at, obviously, we originally thought COVID-19 concentrated on its pulmonary manifestations, but actually we now start to think that it's around multi-system abnormalities and it's related to the microvascular angiopathy. As we know, obviously, calciphylaxis is a condition characterized by tissue necrosis. Then you will see at times patients that are presenting with symptoms like calciphylaxis, but actually it's due to COVID, because we know they are both procoagulant diagnosis associated with vascular mediated cutaneous findings. And always important to remember that patients who are known to suffer with calciphylaxis, they are obviously more at risk of pressure development and can also develop pressure damage where you wouldn't expect to see it. So treatment, obviously wound treatment should be initiated and monitored carefully. We want to prevent further calcification occurring in the soft tissues and prevent any further skin breakdown. We want to minimize the risk of infection. If you've got multiple areas of broken skin, again, we know how much these patients can be at risk of infection. And it may be that actually wound care treatments are to autolytically debride the area. We may want to prepare the wound bed for healing or skin grafting. And obviously we want to prevent any further ischemia because the bandages are too tight. Medication is usually given that decreases calcium buildup in the arteries, usually given during renal dialysis, but sadly treatment options are limited due to the high mortality rate of the disease. I've obviously already mentioned necrotizing fasciitis. That is not an autoimmune condition, but it is a soft tissue infection that progresses really rapidly. And if you've ever seen this, it changes very quickly and it obviously threatens limbs, can cause shock and sepsis, and can also result in death. The infection is usually polymicrobial etiology, so it's usually Streptococcus, Staphylococcus, Pseudomonas. There's usually multiple bugs in the skin, and it can occur following surgery. It's a necrotizing infection involving any layer of the deep tissue compartment. And it's also important to note that actually it can be that severe, particularly if it's affecting a limb, that the only way to stop that infection spreading rapidly is to obviously amputate to prevent that infection spread. Also thinking about necrotizing fasciitis, we've got Fournier's gangrene, and that is a necrotizing infection that involves the genital area. And sadly, it can be misdiagnosed as cellulitis because it presents that red, cellulitic, inflamed, hot, infected looking skin. Or if you've seen it at the stage where it's starting to purple, could it be a DVT? Could it be an abscess? So it is often misdiagnosed in the beginning, and it isn't automatically the first thing you're going to think when you see that presentation. So again, differential. So is it cellulitis? Is it erythema induratum, which is a nodular type of vasculitis, also known as Bayesian disease? And that's usually related to TB. Is it PG? Is it just general limb ischemia or some form of compartment syndrome? Is it DVT, or is it an osteomyelitis that's got some soft tissue involvement? So treatment, really that early diagnosis should be flashing at you, singing Christmas songs in red, because actually that is the most important thing. Early diagnosis is essential for treating neck fascia effectively and safely, and ensuring that that patient survives. Exploratory surgery and surgical debridement might be needed, and obviously thinking about intravenous broad spectrum antibiotics at high doses, you would need microbiology involvement to ensure the antibiotic choice is correct. Some patients may need admission into intensive care unit to make sure they are hemodynamically stabilised. And obviously from a wound healing point of view, the priority is clearing that tissue with infection, stopping that rapid spread, making sure the patient is hemodynamically stable, and then prepare the wound bed for healing and or skin grafting. Optimal wound healing is achieved with the use of advanced wound products that maintain a moist wound environment, absorb exudate, and minimise trauma on removal. But you know, there may need to be required some extensive surgery, skin grafting, or topical negative pressure to ensure these wounds heal effectively, depending on the amount of tissue that was involved. So the final atypical wound I want to talk to you about, which is really close to my heart, is malignant wounds. We know malignant wounds may be fungating or cutaneous, so we know that you may get a primary tumour internal that is fungated through the skin barrier, or you may get a surface level, so a basal cell carcinoma, a melanoma, or a squamous cell carcinoma that's presenting on the skin. We know that the most common sites for fungating wounds include the breast, the neck, the head, and the genitals. And we know that malignant wounds could obviously include the tumours that are fungated through that I've already said. Fungating tumours are thought to be relatively rare, but as we know, patients are living longer with a cancer diagnosis because cancer treatments are so advanced and improving day after day with all the trials that actually patients are living a lot longer with a cancer diagnosis, and that could increase their risk of developing a fungating tumour. We also know that obviously we're excellent now at collecting data in terms of wounds, numbers of wounds, types of wounds, and healing rates. Fungating wounds are not collected currently on all national statistics, and often patients are embarrassed. They don't report these types of wounds. They will sit with them for a long time before they seek help. Again, your differential, always be thinking, could it be something else? So could it be a leg ulcer or an injury? You know, it's not necessarily a BCC or a squamous cell carcinoma. It's your standard run-of-the-mill venous leg ulcer. Is it some kind of strange parasitic lesion if someone's travelled somewhere exotic? Not that anybody's getting on any planes at any moment. Is it a seborrheic keratoses? So that is the most common. They're a common benign lesion that present as people get older, and they're generally found on the back or the trunk. And they're usually like that brown, that big sort of skin change that you see in older people, that brown or black. Is it a dermatofibroma? And they're also benign. They're a fibrous nodule that can occur on the thighs or lower legs, and again are more common in women. We've not been dealt very good here, have we, in terms of the data? Or is it a radiotherapy skin reaction? Is that patient receiving radiotherapy over a mastectomy site, for example, and they've developed the skin reaction, but we're actually assuming that they've got some kind of fungating wound? So in terms of treatment, again, I think as clinicians and nurses, we automatically, any type of clinician that's involved in any kind of care or wound care, we want to make things better. And if you're a wound care specialist, district nurse, you want to put another dressing on to make the wound heal. But actually, it's important to remember that these types of wounds are they're not healed with dressings. We manage the symptoms, and actually the treatment's something else. So for our malignant wounds, we need to think about our chemotherapies, our radiotherapy, our immunotherapy, and manage the symptoms as they present, because again, they can change daily. We need to make sure we're doing thorough holistic assessments, and that's particularly important in patients with fungating wounds. And myself and a co-author developed a pathway to be able to prompt clinicians, district nurses who are looking after patients with fungating wounds to assess people holistically, and that's POSES. So it's looking at pain, being able to assess pain, what can we do to improve that, how can we help that patient. It may be that they've been on systemic analgesia for a long time, but actually there's no blood flow to the fungating wound, so actually the systemic analgesia is not getting to the point of the pain. The O is odour. They can quite often present very malodorous, they can cause patients not to go out, and it is generally related to an infection. Obviously, we've got skin infection. We need to be looking out for those classic signs of skin infection, that odour, and treating that effectively. Obviously, we've missed the E there, but E is exudate. Some of these fungating wounds can absolutely pour very malodorous fluid out. And we don't want to change the dressings too often. We want to make sure that it's just for comfort. So again, the Cliniderm superabsorbent would absolutely absorb a lot of that exudate. And the most important part, and this was added on after the initial POSE was developed, is self, S for self. Is that patient all right? How are they managing psychologically? What other input do you need to call on from other professionals to support them? And obviously make sure you're using suitable wound dressings for the wound as it presents. So in conclusion, those of you that are old enough to know what a Blue Peter badge is, and sadly I am, we know that some of these wounds, you do need a Blue Peter badge, because sometimes you really have to think outside the box to be able to manage them. But the key message that I want you to take from this session is early suspicion. So it's not assuming everything's atypical, but always having in the back of your mind that early suspicion that it may be atypical, that it may be something else, and you may need to get expert assessment, and that is paramount in managing the complex wounds. The watch and wait that we can sometimes do, that can actually have life-changing effects on how the wounds progress, certainly in the necrotizing fasciitis. There's lack of consensus, evidence and research around treating these wounds, and that can make it very difficult. It can make it very difficult to be able to treat them effectively and in a timely manner. And remember, a full, thorough, holistic assessment to establish a clear picture of what is going on. Don't just see the wounds. And obviously Bob the Builder's on there, because I already mentioned, as clinicians, we always like to be able to heal the wounds. It's better for our patients' quality of life. It's better for us. It's better for everybody, for all people involved, that we can get these wounds healed effectively. But dressings, in the case of these types of wounds, will not heal the wounds. They will manage the symptoms, and they are multi-system conditions that present to us as clinicians. And it's important to mention as well, you may have come across lots of these wounds and be very experienced, but actually you may have never come across an atypical wound in your practice before. And it's just important to know that if you do suspect that, it's where you go, who you seek advice from, and make sure that you know that you've got the right people in your area. So very quickly, obviously you heard me mention in the presentation the Cliniderm range. It's a really wide range of cost-effective, comfortable dressings. It comes in a contact layer, a foam silicone, bordered and non-bordered, and then obviously the super absorbent dressings, which obviously absorb lots of exudate from various types of wounds. I've already said they offer quality without compromising on any kind of savings, and obviously they provide equal performance to the market-leading brands, and they offer a comfortable and gentle choice for the patients. A bit slow there. We have got resources, so we've got educational modules through H&R. We have plenty of product brochures, patient information, clinical user guides, pathways and clinical evidence, and we can also do bespoke clinical training for trusts if they had certain areas that they felt that would be helpful, and obviously our contact details are there. Thank you very much.
you, Sharon. That was absolutely brilliant. Brought back memories of some of the patients that I looked after, and because they're few and far between, they're quite memorable, aren't they?
Yeah. And even when I was
Yeah.
putting this presentation together, I was like, oh, I can remember that patient.
Yeah, I can remember patients that I've looked after with nearly all of those conditions, I think. So, okay, so we're going to move on to the question and answer session now. Remember, everyone, you can still take part and ask questions at any time by commenting on the video. Okay, so moving on to our first question, which is from Christine. Inflammation can be problematic in atypical wounds, but steroids reduced healing. So how do you balance this?
Yeah, and that is a challenge, yeah. And we know that obviously with steroids, we know that obviously the inflammation in the wounds can be challenging. We know that it can be misdiagnosed as infection when actually it's that inflammatory response to the autoimmune condition. And it's about recognizing that actually these wounds will respond to steroid treatment, whereas standard wounds won't. And it's about getting the balance right, isn't it, with the doses and stuff. And, you know, like I said, there's very little scientific evidence to show us, you know, it's not black and white, is it?
No, you're quite right.
Christine, you're absolutely right. And that is why I think this topic was important, because it's so challenging for everybody.
Mm-hmm. Brilliant. Okay, question 2 is from Kath. Good one. Would applying compression help with pyoderma gangrenosum?
Yeah, so obviously I didn't mention compression, but we've talked about a lot of the ulcerating conditions that do affect the lower limb. And yeah, you know, if you can improve blood flow, if you've got a patient who may already have an element of you know, venous insufficiency, absolutely compression can help improve that blood flow to heal the area, providing you know you're treating a pyoderma, providing you're looking out for those symptoms and managing the treatment of that. But yeah, absolutely.
Great. Okay, a very topical one next. We know that patients with COVID-19 are more at risk of vascular skin changes. And knowing that they have various medical devices in situ, what would you recommend?
Yeah, really topical. And I know I've worked with a TVN in my area specifically looking at this. You know, we know from data that was produced pre-COVID that actually respiratory devices are the most common causes of medical device-related pressure ulcers. And like we've said, we know that you've got that procoagulant condition and part of COVID. It's just about using your normal pressure ulcer prevention packages. So whatever you use in your area, your skin bundles, repositioning devices, removing devices when they're no longer needed, you know, monitoring them and checking that skin integrity, you know, around the face, around the nose and the ears. That is so important.
Yeah, okay. So the next one's from Lindsay. Does infected pyoderma ever get mistaken for calciphylaxis? And how can you tell the difference?
So obviously, calciphylaxis generally presents like a necrotic wound, and because obviously it's quite rapid in its presentation, the blood flow stops very quickly in terms of that calcification in that blood supply. So generally, it does show as necrotic tissue quite quickly. Pyoderma, we know that obviously, you know, when you think, and again, like you said, I'm thinking back to patients that I've had, when you think about taking a dressing off and you see that blue-green exudate on the dressing, you know, those of us that have been around a long time can go, oh, I know what that's infected with. I can tell by looking at it. So again, it's recognizing and looking at the symptoms of the ulceration and seeing that actually it's bleeding. So you've got a bleeding pyoderma, you've got a blood flow there, but you've got that blue blacky green tinge around the edge. You know, we're not always going to get this right 100% of the time, you know, and different clinicians will look at different wounds and think things different, but it's just about recognizing and actually what's going on in the past medical history. Have they got an autoimmune condition? Have they got renal disease? So it's not just looking at the wound, is it? It's looking at what else is going on in the bigger picture.
Yeah, quite right. Okay, so the next one's from Debbie. What is the incidence of bullous pemphigoid in the general population?
I've no idea. I don't know. I know that obviously in terms of the whole wound, you know, the wound numbers, we know that atypical wounds are 20% roughly, but we know that wounds are always reported, they're not always captured, they're not always diagnosed early enough. So, you know, I'd be happy to get back to you with more information, but again, I still think that it wouldn't be an absolute, this is black and this is white.
Yeah.
Because they just don't get reported, they don't get diagnosed, and especially at the moment, you know, the world's a strange place where things aren't being done as they normally are.
Perhaps Debbie was thinking, how likely is she to see that in her practice, maybe?
Probably unlikely, you know, and obviously like you, Claire, I mean, I know obviously you've got a long tissue viability history. You know, when I think I've been in wound care for 16 years, I probably only had one patient that I can think of and remember. It's very, very rare. But when you do see it,
you never forget
important.
it. So some homework for us. We'll find out and let Debbie know.
I'll do some searching.
Okay. Question 6. What's the best treatment for radiotherapy skin reactions?
Yeah, so I did a lot of work with this when I was a tissue viability nurse. So obviously there was a lot of work around the Society of Radiographers, and they did produce guidelines around preventing skin reactions. And it was always, again, very topical, very difficult to evidence base. And what we say now in terms of radiotherapy is obviously use your normal products. So we don't ever want anyone to start anything new prior to treatment. We don't want them developing a sensitivity to a new moisturizer or something like that when actually we're thinking it's radiotherapy. And it depends on local policy and guidance. It depends what your trust or area advises. But polymem dressings are an excellent treatment for those sort of RTOG2. So where you've got the broken, tight, inflamed erythematous skin that's weeping, but it's also got the really tight, dry skin. That I'm doing this because it's mainly head and neck that we see it most often, where the skin's so tight, you know, the patients are unable to turn the neck. And how the polymem works is it absorbs obviously the exudate from the weeping areas. It's got the glycerol and the surfactants, so it's got those cleansing agents and moisturizing agents to put moisture back in, to reduce that inflammation, to encourage the healing and just make the patient feel more comfortable.
Brilliant. Okay, the questions are coming in thick and fast.
Oh my word, I'll have to get another cup of tea.
So the next one, can we use the polymeric membrane, which has anti-inflammatory properties, instead of silicone foam? Do you have any experience of this that you can share with us?
So obviously the polymemic membrane is polymem, and yeah, you could use either of those dressings. So polymem is obviously the polymembric foam that I just talked about, that's got the additional benefits of reducing the inflammation, absorbing the exudate, and obviously cleansing a wound and moisturizing a wound. Obviously silicone foam is an absorbent foam. It's gentle, it's got the silicone contact layer, it's got the soft adhesive to it that's atraumatic on removal. And it just depends on what you're wanting to achieve from your dressing, or what type of wound presentation you've got. You know, if you've got a very painful wound, so we know that some of these autoimmune lesions are really painful, then you may want to consider using the polymemic membrane, the polymem, over the foam silicone. It's just what you're wanting to achieve in terms of what you're managing from the wound.
Okay, brilliant. Right, the next question is, what is the best product to use on tattoo on a tattoo for aftercare?
It depends on personal choice, really. And, you know, there are lots of tattoo aftercare creams out there, but, you know, ideally you want something that has not got any added sensitivity, you know, that's going to cause a sensitivity. So we know lanolin is probably, we could have a debate about lanolin all night, really. And I'm sure we've all got our own personal opinions. You want something that's got nothing in that's going to cause any sensitivities, that's going to make the wound more at risk of contamination. You want to use something that's clean, on clean hands. Ideally, you want something that's got an SPF in it to protect your skin, particularly if you're lucky enough to find any sunshine, although it was lovely today. And just something that's going to protect the tattoo, that's going to, you know, not dry the tattoo out, but not keep it really moist and damp. So just something that's, you know, that's plain and simple.
Brilliant. Okay. Next question is, what do you recommend in terms of odour control with fungating malignant wounds?
Yeah, and obviously, like I said in the presentation, and You know, I was a TVN in an oncology hospital, so I had a huge input with fungating wounds, and that's why I'm really passionate about them. They are malodorous, and you know, it's important to rule out the cause of the malodor first. Is it the fact that it's a fungating wound and there's a lot of necrotic tissue due to that blood supply, you know, not being what it was because it's that tumour, or is it because there's an infection there? So it's making sure that we're actually know what we're doing in terms of managing what the cause of the odour is. If it's obviously infection, we want to use systemic antibiotics if they're appropriate. We want to use topical antimicrobials. You know, there's various research around different types of topical antimicrobials and their effectiveness. You know, there are charcoal dressings which can be effective, but sometimes if your wound's really wet, we know that charcoal becomes inactivated when it gets wet from exudate. You know, if your patient with a fungating wound is under a specialist oncology hospital, you know, like the Christie in Manchester, they have people who have done significant amount of work, PhD level, looking at essential oils to manage odour. So there's lots of, you know, out of the box things that we can do for odour, but obviously those kind of things you're always going to seek specialist advice. You know, you're going to take that from somebody who is the expert.
Brilliant. How can further calcification be prevented with calciphylaxis?
Yeah, and it is really challenging. Yeah, it's so problematic. And obviously we know, like I've said, it can be so debilitating and have quite a poor outcome for patients. In terms of preventing further calcification, obviously, you know, patients receiving renal dialysis or have got calcium imbalances, they will be treated to manage the level of calcium, reduce the level of calcium that they are producing. Obviously, we're not going to want anybody wearing really tight compression stockings that are then going to cause further friction and cutting off the blood supply. We don't want to be putting bandages on that are too tight. And also it's thinking about patients at home. You know, are they sitting for hours in the chair? You know, it's just thinking about things that are going to have a negative impact on blood supply. Are they wearing really tight clothes because that's all they've got? So it's just thinking about preventing that further damage to that blood supply in the tissues.
Okay, and the final question comes from Kate. Kate's currently looking after a patient with a malignant wound, which is a tumour.
Yeah.
It has several openings and a large amount of exudate. What would be the best absorbent dressing?
I mean, with your openings, then it depends on how deep they are. You know, are they packable? Can you put packing in to absorb? But really, you want something that's really, really super absorbent and really conformable. So you want a dressing that is big in size. So that can be a challenge as well. Coming back to the Blue Peter badge, if you've got a large sort of lesion, a fungating tumour that's you know, presenting from the skin, they can be really difficult to dress because they're not flat, they're not nice in a nice body area, they're really challenging. So you want something that's super absorbent, that you're going to be able to cover the wound, that's going to absorb lots of exudate, so that you're not going to have to keep changing the dressings often. Your patient's going to be comfortable, and making sure that obviously the whole of the tumour is covered, and you've got a nice gentle adhesive to keep it in place, so you're not going to get that leaking out from under the dressing.
Fantastic. Thank you so much for answering all those questions, Sharon.
Thank you,
that's
Claire.
brilliant.
There's some good questions, wasn't there?
Very, very good questions. Yeah, there always are. They're brilliant. Yeah. So this concludes our live training session. Thank you, everybody, for all of your comments and questions. Your interaction has been brilliant. And thank you so much, H&R, for your support tonight. The certificate link should be on your screen now and will also be pinned to comments. You can like the GPN Facebook page if you would like to hear first about any new events. So take care, everyone, and we hope to see you again very soon. Thank you.
Thank you.